Welcome back, everyone, to the final session. It's my great pleasure to introduce Corey Ranger, who is the president of the Harm Reduction Nurses Association and clinical nurse lead for the Victoria Safer Initiative. He is also a board member for the HIV Legal Network and instructor for the Homelessness Service Association of BC. And today he'll be presenting about implementing the Victoria Safer Initiative. Thanks, Corey.
Thank you so much for having me. So I do want to start off, of course, with disclosures and managing potential biases. I have no conflicts of interest to declare. Our program, which we'll learn soon, received financial support from Health Canada in the form of grants from the Substance Use and Addictions Program, or SUOP. This program receives in-kind support from the Canadian Institute for Substance Use Research and Solid Outreach in the form of research and evaluation. They are our partners in this work. And of course, I guess my potential conflict of interest is that I am a paid employee of AVI Health and Community Services as their clinical nurse educator. Have no commercial interests to declare. And when managing potential biases, as with any programs that work with people with lived and living experience of criminalized drug use, is that we mitigate our bias by ensuring our work is centered on the feedback and insights, and that occurs through our research partnerships. As was said before, my name is Corey. I'm a registered nurse. I'm the clinical nurse educator here at the Victoria Safer Initiative. And today I'm really happy to be speaking to you about our project and about implementing a safe supply program in the dual backdrop of public health crises that is both COVID-19 and the global pandemic. Victoria Safer Initiative received funding from the Substance Use and Addiction Program in June of 2020. And we were originally given 8 months of funding in order to develop, implement, and evaluate a flexible and harm reduction model for the provision of pharmaceutical alternatives to the toxic drug supply, aka prescribed safer supply. And before I carry on any further, I would like to acknowledge that we work on the lands of Lekwungen people, lands which continue to be violated by colonization and whose people continue to resist ongoing genocide. We honor the life force of the territories and the people of these lands, including all Indigenous people living on these territories who have been forcibly displaced. Ending the overdose crisis is deeply connected to decolonizing work. There is a link between colonization, which is fundamentally a process of violence and disconnection that operates on many levels, and the topics we're here to discuss today, namely the war on drugs on the land commonly referred to as Canada. Land acknowledgement is not enough, not even remotely, when it comes to eliminating structural and historical barriers erected through colonization, but it is a small step towards humility and an agreement to continue to work to decolonize the way that we offer services to people and the way that we try to eliminate the harms from the war on drugs. I also want to acknowledge that this presentation, the work that we do at the Victoria Safer Initiative, the work that everyone does in harm reduction, was made possible by people with lived and living experience of criminalized drug use. And because of their willingness to share their knowledge and experience, that's why we have this program running. These individuals share their knowledge and experience with us, and without their generosity and patience, this work wouldn't be possible. I also want to briefly center what we're talking about today on harm reduction. It's important to note that there are many different versions or definitions of harm reduction, and the Victoria Safer Initiative is intended to be a safe supply program that is delivered through a harm reduction approach. Now, that may often be viewed as a public health approach, which is essentially risk reduction, but there are other ways that it should be looked at, and one of the really important ways of looking at it can be explained if you take some time to review a YouTube video from the Western Aboriginal Harm Reduction Society called Taking Care of Each Other, Hopes for the Future. In that video, what they say is that mainstream harm reduction practices such as naloxone distribution and opioid substitution therapies have been proven to save lives, but they narrowly focus on substance use behaviors and do not address the broader social and system-wide issues that contribute to and interact with substance use for Indigenous people in the first place. For Indigenous communities, harm reduction means reducing the harms of colonization. And truthfully, when we're talking about the harms of the war on drugs, when we're talking about the devastating amount of people who are dying at the hands of the toxic drug supply, when you look deep enough, that is colonization and racism and white supremacy. And so the work that we do in order to provide a safe supply to people and to do it in a way that is low barrier and accessible is an attempt to rectify some of the harms that have been instilled by the war on drugs and colonization. It's also important to note that harm reduction is rooted in principles. And one of the most important principles for harm reduction is that options for treatment should be ethical, evidence-based, accessible, and non-coercive. And that's really important as we move through this presentation, because those are some of the principles we try to use to guide our work. Now, it shouldn't be any surprise to people who are attending this conference that the overdose crisis, the toxic drug supply, continues to worsen year over year. Here in British Columbia, toxic drug supply, toxic drug policy killed 2,224 British Columbians in 2021. And as you can tell from the bar graph, it's continuing to worsen. And what's truly tragic is that 71% of those dying are aged 30 to 59. There's a lot of discussion, there's a lot of belief in other provinces that BC has a safe supply, that people are able to access a safe supply. And that's not actually true. In truth, there's around an estimated 90 to 100,000 British Columbians who would be at risk of overdose, who are accessing the illegal supply and are in turn potentially at risk of negative health consequences from that volatile and toxic supply. And approximately 3,600 of them have been able to access some form of a quote unquote safe supply. What that equates to is less than 4% of people have actually been offered or been able to access some form of a safe supply. And so if you're looking into BC from a different province, thinking that we've got it all figured out, the truth is that safe supply is widely inaccessible to those who need it at this point in time. Part of the reason why things continue to get worse, even though we have more access to overdose prevention sites, we have more access to supervised consumption services, we have been able to innovate in the toxic drug supply crisis, is because drugs are continuously criminalized and people who use drugs are criminalized. And the iron law of prohibition states the harder the enforcement, the harder the drugs. And so we're constantly playing catch up in the world of safe supply and prescribed safe supply, because the drug supply is evolving as well. And even now, if you look at this section for down and you see opium moving to heroin, moving to fentanyl and carfentanil, there should be an additional fourth arrow now, which shows fentanyl and carfentanil contaminated with benzodiazepines, because that's what we're seeing here in Victoria and in the rest of BC is widespread benzodiazepine contamination in the drug supply. When we first started doing this work, before we even received funding from the Substance Use and Addiction Program, I was working for AVI Health and Community Services in Topaz Park, which was one of the state-run homeless encampments. Actually, 2 years ago today, we were doing this work. And right around that time, we noticed a change in the drug supply. And there was a significant increase in overdoses that we're seeing right on the ground level. And what happened was the perfect storm with COVID-19 restrictions coming in place, border closures, people being encouraged to isolate and socially distance, which isolation and overdose are a bad mix. We saw a rapid increase in people overdosing. And in the check week for April of 2020, just working in the one homeless encampment, we had 28 overdoses over the span of 1 week. And a number of them on check day. And what we noted right at that time was that atizolam and other substances had started to become more mainstream in the drug supply. We also saw a significant restriction in access to services at the onset of the pandemic. Many shelters closed, consumption sites reduced their capacity. And what that meant was that people were left on their own with this increasingly dangerous drug supply. Just to take a little bit of a step back, it's important to talk about what a safe supply is. And a safe supply truly is access to a regulated supply, and it is low barrier access to a regulated supply of drugs as a replacement to the toxic drug supply. And if we do it right, there's a lot of benefits that people can experience. And the most important one for me, and probably many of you, is less overdose. Every year, the overdose crisis kills thousands of Canadians, but Safe Supply can reduce the impact of the contaminated supply by providing consistent and regulated alternatives to illegal drugs. But we also will be able to see less police intervention because through the provision of a legal and regulated supply, we reduce the likelihood that people will be unjustly criminalized for their substance use. When people have access to a safe and regulated supply, there's less likelihood that they'll experience chaos in their lives and more opportunities for stability. When we reduce overdose, police intervention, incarceration, and disease transmission, we also save money. And when people have access to a regulated supply and they have their basic needs met, Safe Supply can also foster positive relationships with service providers and create connections to care that promote trust and better health outcomes for all. When people have access to a regulated supply, there's the potential that we reduce stigma, because at the root of stigma is criminalization of substance use and the criminality that fosters stigma and discrimination, which forces people to use in isolation. We also know what's really important to people is that a safe and regulated supply can reduce the likelihood that they experience withdrawal and peaks and valleys in their tolerances. And Safe Supply is an important gateway to change on a systemic level as well. Safe Supply is a valuable step so that we can move towards even more important pieces like decriminalization and legalization and regulation of substances. Now, what we actually got when Safe Supply was first rolled out in BC was not really true safe supply. What we got was this document to the right here called Risk Mitigation in the Context of Dual Public Health Emergencies. And when this came out, there was a lot of fanfare. A lot of us believed that this was going to be a safe supply and that this was going to be helpful to people. And it may have helped some, but what we noticed really quickly is that there were some very critical flaws in this first approach. And the primary flaw was that COVID was being tied to safe supply. It's a high likelihood that the people who originally offered these guidelines saw COVID as a potential door opening so that safe supply could be rolled out. But when they created this document, they made it as a risk mitigation for COVID-19. What they believed is that people who use drugs would get sick from COVID. They would have to isolate. When they isolate, they would not be able to access the regulated supply. And so a number of Dilaudid tablets or hydromorphone tablets would be prescribed to them as a means of reducing the likelihood of them withdrawing and to keep them supported while they isolate during their COVID infection. The problem with that was that it gave safe supply prescribing the air of impermanence. It made prescribers believe that once COVID was done, that this option for prescribing would no longer be viable, which creates ethical distress and moral dilemmas for prescribers as well as other service providers. Another issue was that the risk mitigation guidance documents were framed as a withdrawal management tool, as treatment. And what that does is it fails to acknowledge that people use drugs for a number of reasons, not just to avoid feeling sick or not just to avoid going through withdrawal. And if we're only prescribing it to avoid going through withdrawal, we're failing to meet the needs of a large number of people who use drugs. Another problem with the first iterations of safe supply prescribing during the pandemic was that it failed to acknowledge what people were actually using, what their tolerances were, what their actual wants and needs were when it came to a safe supply. And so if you look at this comparison here, you'll see that the standard prescribing of hydromorphone pales in comparison to what people are taking from the illegal supply. And so if someone is prescribed 12 tablets of Dilaudid, that's the morphine equivalency of 384 milligrams. But if someone is using 5 points of down from the illegal supply, that equates to anywhere between 1,950 milligrams to 7,400 milligrams. And this information comes from Substance, which is our next door neighbors at the Safer Victoria Initiative. They're the Vancouver Island Drug Checking Project, and they regularly compare and contrast concentrations of fentanyl and average concentrations that they find in their drug checking. Our program is intended to be a flexible model for safe supply, and that's not just a buzz term that we use. It's an actual category of safe supply prescribing models that was developed by Health Canada and partners. And so there's a traditional, enhanced, and flexible model. A traditional model looks a lot like an IO clinic or an OAT clinic. An enhanced model is intended to be something more comprehensive and dedicated, like the Crosstown Clinic, or perhaps embedded services like the Molson Overdose Prevention Site that does a tablet injectable opioid agonist therapy. Now, to the right, there's this green category of flexible models. And if you look at the characteristics of a flexible model, those are ones that are intended to be low threshold, harm reduction and public health informed, embedded in primary care, consumption sites, overdose prevention sites, or housing with pathways to health, social, and addiction treatment services if that's what that person wants. And when there's only a few programs who kind of exist in this category, and I would say, truthfully, to be flexible means to be consistently pushing back on medicalization. And so we are within our program and other programs across the country that are trying to operate a flexible model for safe supply. We are at the uncomfortable intersections of harm reduction and addiction medicine, which are not always in congruence with each other. And we work with these amazing group of doctors and participants and researchers who understand that tension and sit with the discomfort of that and attempt to push back on medicalization as much as possible within the existing frameworks and legal parameters. Now, our program, as you'll learn, exists upon a continuum, and the continuum can look a lot of different ways. This is a different way of looking at the model that I previously showed you, or the table that I previously showed you, in that there are many different ways that safe supply can be implemented and can be made available to people. And we are currently hyper-focused on this small little area that is medical or clinical delivery of safe supply. And there are folks who will need to access a medicalized safe supply. There are people who benefit from going to see a doctor or going to see a nurse. With that being said, the majority of people don't need to, and we haven't made enough concerted efforts to invest in, models that are truly demedicalized, like heroin compassion clubs, like legalization and regulation of substances and made available through dispensaries and other models. Public health models haven't been explored enough. And so the Victoria Safer Initiative lives somewhere in the middle here, where we are pushing as much as we can to get to where we need to see, which is all models fully invested and explored, so that wherever you are in the drug use continuum, wherever you are in your journey, you have a place that you can go to and you can access what you need right then and there. So as I said, the Victoria Safer Initiative got its funding in June of 2020, and we started off concurrently by running clinical services right away. We wanted to act with a sense of urgency and to start offering options to people right away. And so myself and our support workers with lived and living experience of criminalized drug use and our systems navigators started working in all 12 of Victoria's homeless encampments, connecting people to tablet safe supply options. At the time, the only option available was hydromorphone. And while we were doing that, we also concurrently started doing service design engagement and consultation with people who use drugs. And so this first report here was a community engagement report that we completed with both people who use drugs, but also with prescribers, with nurses, with researchers. And we wanted to get just a preliminary understanding of what people's needs were. And we got a lot of really great information from there, but we knew that way more consultation and engagement with people who use drugs needed to happen, because truthfully, they should be the one who lead this work. And it should be our job to try and remove barriers, hear what they say, and to try to uplift and affirm those thoughts and feedback so that we can provide something that truly is effective and accessible. So we completed a service design and engagement project in partnership with Solid Outreach and the Canadian Institute for Substance Use Research. And what we did was we completed a round of focus groups with people who use drugs. We did 7 initial focus groups, where we did focus groups with people who inject their drugs, people who smoke their drugs, people who were sleeping in parks, people who were sleeping in the temporary shelter locations, people who are First Nations, Indigenous, or Métis, people who engage in sex work. And we asked them all one centralizing question, which was, safe supply would work for me if. And hundreds of responses were given to us, which were then boiled down and put into different categories by researchers and research associates with lived and living experience, and 6 primary categories were discerned. People wanted the right dose and the right drugs for them. And what that meant was that people wanted access to a safe supply that reflected what they were actually taking. They wanted it to be in the route of consumption that they actually use it in. Here in BC and in the rest of so-called Canada, large number of people who are overdosing and dying are people who smoke their drugs, yet there continues to be no smokable options at this point in time. People also wanted safe, positive, and welcoming spaces. They wanted safe supply and other services that were accessible to them. They wanted to be able to be trusted with their prescription. They wanted doctors who understood dope, and they wanted doctors who would not label them with a substance use disorder diagnoses, but instead listen to them and say, what is it exactly that you need? And to really truly understand that we are trying to mitigate the harms of the toxic drug supply, not coerce into treatment, not to uplift our priorities and goals for the participant, but to truly listen and try to respond accordingly. People wanted to be treated with respect. They wanted to be able to easily get their safe supply without having to jump through a number of medicalized hoops and barriers. And what's most important to me here out of these categories is that respondents wanted safe supply that helps them function and improves their overall quality of life as defined by them. And so often the goals and priorities of people who use drugs are not truly respected when people are interfacing with care providers. And it becomes a matter of the prescriber or the team's priorities, not that of the individual trying to access a safe supply. This work has now been published, and it is available both on the federal government's preliminary evaluation of their SUOP safe supply projects. It's also available on the collabbc.ca website. You can see that there is these postcards, but there's also something called a safe supply checklist, which we hope will help inform future programs who are looking to provide a safe supply and to do it in a way that is less oppressive and less high barrier than the existing medicalized models. Our program is about flexibility, and it's also about having an iterative approach. In the first 8 months while we were completing the concept mapping and trying to do clinical delivery via outreach, we also really adapted our program and changed our program as organically as possible based off of the feedback that we got. We had a period of time where people were unable to get to the pharmacy. We had folks who had mobility issues and were sleeping in tents and weren't able to get to the pharmacy every single day. So we rolled out a medication delivery program. We brought the medications to them in the parks. We also quickly revised the risk mitigation guidance documents and rewrote those documents so that they were delivered through a harm reduction approach. And so immediately we rewrote those clinical documents and removed COVID-19 risk as one of the criteria. We intentionally divorced ourselves from the pandemic so that it wasn't having that air of impermanence. We also added drugs like oxycodone because anecdotally, participants were informing us that they were able to smoke their oxycodone, and we wanted to have some form of a smokable option available for folks. And we also increased the dose ranges so that we could actually attempt to reflect the tolerances of what people were actually using. Our program is also about a harm reduction service delivery model. And so within that model, we operate a person-centered approach. And what that means is that participants take the lead on identifying their needs related to substance use and are supported by an interdisciplinary team, and that we employ harm reduction principles such as nothing about us without us and offer pharmaceutical alternatives that best match the participant needs. We have outreach workers and support workers on our team with lived and living experience of criminalized drug use, and they're a vital bridge between participants and clinical staff, helping to foster trust and connections to care. When our program first started, if it was just me walking through the parks talking to people about a safe supply, we likely would have had very little uptake. But having folks there who could actually utilize mutuality and authenticity was key in the early days of SAFER and continues to be key as we move throughout all of this work. We have nurses who work up to full scope to build trust and assess participants. And ultimately, the nurses listen to participants to determine the best fit of safer supply. On our intake form, there's a section that says, what do you need from a safe supply? And that really is our cue to make sure that we are consistently listening to people who use drugs instead of trying to fit them into categories and containers. We have 6 physicians currently working on our team, and these physicians take a harm reduction approach by centering participant identified needs and taking a collaborative approach with the interdisciplinary team. They truly do try to work from an anti-oppressive lens and put a lot of trust in the frontline care team so that we can be the main points of contact with participants who are trying to access these services. And then we have these wonderful team members called systems navigators. And a systems navigator is an individual who offers psychosocial and practical supports to reduce the systemic harms to health and well-being. And what they're really doing is they are knocking down barriers to people accessing their safe supply. When we first started doing this work, we realized very early on that it wasn't just about a prescribed safe supply, and especially through a prescriber-driven model, we knew that many people experience barriers in being able to access those medications. Lots of folks didn't have birth certificate ID, medication coverage. Their lack of housing was a barrier to accessing their safe supply. And so our systems navigators work with participants to address all of those barriers and more, like legal assistance. And at present, over 90% of our participants are engaged with systems navigators in order to address the many systemic oppressive barriers that they experience. Now, when we were first doing this work and right up until we received a funding extension, we knew that we only had a short amount of time. And so we created a little bit of a feedback process towards the end of our 8 months of funding. And we asked participants to let us know what the notable impacts of receiving supports from SAFER was. At that time, 54% of SAFER respondents reported that they had been able to reduce potential harms from substance use. 53% of SAFER respondents reported a positive social or health outcome enabled by SAFER support, and many of those outcomes include reduced use of illegal substances, safer use practices, decreased cravings, decreased withdrawal symptoms, healed wounds, improved mental health, increased connections to healthcare, less reliance on street economy, improved overall function, reduced use of illegal substances, and connecting to social supports. And then we received an additional 2 years of funding. And at that point, we knew that we needed to go back to the feedback that had been given to us from participants about wanting to be able to access a safe and supportive space, and that people wanted to be able to access drugs that better reflected their use and what their needs and wants were. So in a very short turnaround, in June of 2021, we renovated an old pizza restaurant and turned it into our Victoria Safer Initiative clinic. Our clinic is also a designated overdose prevention site. As you can see, there are booths there. And we did that renovation and turnaround in a matter of 1 month. And then we started bringing people in so that they could start offering and receiving other pharmaceutical alternatives besides the community-based tablet hydromorphone and oxycodone. Now at the Victoria Safer Initiative, we have 3 different arms of interventions that people are able to access. We continue to support a large number of participants via outreach who are benefiting from their hydromorphone or oxycodone tablets. We still do offer stimulant-based options for people who use legal stimulant supply via dexedrine, Ritalin, or Adderall. However, there's only a small amount of people who really are sticking it out with that because we need to continue to explore better stimulant options for people. We also added short-acting options within the clinic. And so now people can also receive up to 4 doses a day of injectable or sublingual sufentanil. This is the sufentanil program where it is a PRN or as required program. People can come in every single day and receive their doses. People can also miss 20, 25 days of their doses and still come in to receive a dose without having to jump through a bunch of barriers. It is, in essence, a more flexible IOT program. It doesn't stick people onto a regimented schedule, but it gives them the freedom to come and go as they need. We also added a fentanyl tablet program called Fentora. This is a dissolvable effervescent tablet that people can take BID or twice a day. The fentanyl tablet program goes up to the highest doses so far as 2,400 micrograms twice a day. And then we added a long-acting option, which is the fentanyl patch program. We still do have folks who benefit and stay with traditional OAT. And so we've got participants who are on a combination of short-acting, but are still on their Cadian or their methadone. And truthfully, a participant can be on any combination of these three different options because it's about tailoring according to what the participant's goals, needs, and preferences are. We have people who are on a fentanyl patch, but they also come in a couple times a day in order to get their injectable sufentanil. We have people who are on their Cadian and Fentora, and they still can receive a small amount of Dilaudid tablets if they are going to be using something later on in the night, and their goals are to reduce or eliminate the amount of times they're accessing the illegal and volatile supply. And when we're able to actually match up the intervention options based off of what the goals of the participant are and what their use patterns are, we actually start to see some really positive impacts. And so recent stats that we have, we've connected over 200 people to a safe supply, and we're working very closely with around 108 active participants. That number tends to fluctuate at times. We have around 25 people who are currently receiving their fentanyl patches. We now have over 20 people who are getting their sufentanil up to 4 times a day. We're up to 12 people who are getting their Fentora. And I believe we're at around 10 people who are receiving a combination of fentanyl options. And we're learning a lot from being able to offer these fentanyl-based options and by creating feedback loops where our participants can tell us how the program is or isn't working for them. This is just a little bit of a snapshot of what one day looks like at the Victoria Safer Initiative. So on a busy day, a few weeks ago, offering Witness Pharmaceutical and other safe supply options, we had 30 individuals who came into the clinic to get their safe supply, with 65 drug dispensations happening at 4 booths over 7 hours. 43 of those were sufentanil doses that were utilized by 18 unique individuals, with 8 individuals coming in to get their Fentora tablets and 10 people getting their fentanyl patches changed, and over 100 people accessing a safe supply in combination through our clinic and our outreach team. We are also a primary care clinic, and so our participants access their safe supply, but we have a physician in the clinic every Tuesday afternoon and all day on Thursdays. We work with people on clearing Hep C. We do blood work with them. We do chronic wound care management with them. And we really do try to provide as comprehensive wraparound supports as possible. So after we were able to open this clinic and we were able to start seeing what would or wouldn't work from a fentanyl-based option, we went back to our participants and asked them to give us some more information now about how they were feeling and how they were experiencing the program. And so we went back to these notable impacts and we asked the questions again. And this time we heard that 73% of safer respondents reported reduced use of illegal substances. 73% of safer respondents reported increased connections to healthcare. And again, 73% of safer respondents reported less reliance on the street economy. 65% of safer respondents reported decreased experiences of withdrawal, and an additional 65% of safer respondents reported increased connections to social supports. There's a quote here on the right from one of our participants. "They've helped me decrease my overall drug use and have helped me manage my withdrawal symptoms. After nearly 4 or 5 months of using patches, I'm attempting to find work." And those are some of the less tangible but so valuable connections that people have been able to experience. We had individuals come up and tell us that they were able to attend a family dinner for the first time and that they felt like their stability had improved and that they were able to start working on other goals. And truthfully, what Safe Supply is about agency of choice and about meeting those basic needs so that people can then navigate the rest of their lives and decide what next priority they want to work on. And it's not on our job to impress upon them what our goals are, but we really do make sure that we're trying to help them move along the continuum as they see most importantly. Now, there is a lot of contention around prescribed safe supply, and so we do a lot of work to make sure that we're validating the practice that we do. And there's this common misconception that prescribed safe supply increases risk or that there's a potential concern around it. But a report from the BC CDC showed that of the 2,780 people who are identified as accessing RMG or the provincial prescribing between March 27th and August 31st, less than 0.4% of them died by overdose. And among those 0.4%, those individuals still had the illegal fentanyl in their systems. And so what this tells us is that we need to continue scaling up life-saving prescribing practices and expand their reach in tandem with support and expansion of lower barrier, demedicalized, community-driven models, as well as working on decriminalization, legalization, and regulation. It's not about one option being a panacea. It's about people having a menu of options that they can navigate and make the choices as they see best. We also want to make sure that the work we do is in alignment with ethics. The BC government commissioned an ethics analysis related to prescribed safe supply, and that ethics analysis is available by request to the Overdose Emergency Response Center at the province. And they asked all of these important questions related to potential ethical dilemmas of prescribed safe supply. And what were the results of this ethics analysis? Well, it was an unequivocal support for scale up of prescribed safe supply. Some of the important quotes from that ethics analysis include: a healthcare professional would have an ethical obligation to prescribe a medication that would allow the drug user to avoid having recourse to a toxic drug supply, rather than the professional insisting on only prescribing on the condition of engaging with individualized medical treatment that extends beyond what the individual specifically requests. Furthermore, as has already been pointed out, even if diversion were to occur if witnessed administration was not required, it would reduce the overall reliance of other drug users on a toxic drug supply. And lastly, if the data demonstrates that prescribing reduces the risk of harm, failure to prescribe could violate healthcare professionals' ethical obligation to a patient. So we combined that ethics analysis, we combined the feedback from our participants, we added in the concept mapping and engagement data that we received, and we put together a practice brief called Implementing the Victoria Safer Initiative. That is also available on the collabbc.ca website. And so if folks are looking for that package, that's something that they can have publicly accessible to them. Over time, we've continued to adapt and change our clinical guidance documents, both for community-based options of tablet safe supply like oxycodone and hydromorphone, but we have also adapted from and in consultation with Dr. Christy Sutherland from Safer Vancouver, the fentanyl patch, Fentora tablet, and sufentanil program. These were all put together and adapted based off of our participant feedback in consultation with, like I said, Christy Sutherland, but also nurse researcher Megan Brown, and approved by our medical team. And all of these prescribing protocols are also available upon request. We want people to be able to have something that's accessible and adaptable so that it is easier if you are a prescriber and you're looking to try to do this work. How can we create a community of practice and solidarity amongst prescribers so that that work is easier to do and you don't feel like you're doing it exclusively in isolation, which can be oftentimes morally distressing for some. Our program is also tied into the provincial risk mitigation guidance evaluation, which employs a mixed method approach of qualitative interviews, quantitative surveys, and chart reviews. One thing we know for sure is that people are hungry for evidence related to this practice, and that we need to continue to both innovate and be flexible, but to be able to participate in as many studies and evidence generation as possible, so that that body of evidence does develop. It is a novel approach. It is something that hasn't been done before, or at least hasn't been done on such a large scale. And so we know that we need to continue to work on developing that body of evidence for future growth of this practice. This is just a little snapshot of some of the other things that we do at the Victoria Safer Initiative. We make resource development. We do resource development to try and support people, even if you're not part of our program. We do try to support folks in accessing a prescribed safe supply by liaising and advocating with their family doctor. And so we do resource development. We're also exploring new medication options on a regular basis, particularly wanting to explore smokable safe supply options as well as better stimulant safe supply options. I alluded to before that the stimulant safe supply options were hit or miss for folks. And what we found is that, the people who have benefited from accessing the Dexedrine or Ritalin or Adderall have been people who have been living with untreated or undiagnosed ADHD, which there often is a link there with stimulant use. But for the most part, we know that those options do not really reflect many of the needs and wants of people who use stimulants. And so we need better drugs available for folks who are using stimulants. And we also work on educational tools. We know that pilot programs and small programs have limited capacity. We know that there's always challenges with precarious funding models and that there are concerns with pilot studies. And so our goal often is to try and work ourselves out of a job, which means supporting and building capacity with other teams, other prescribers, other jurisdictions, so that these programs and services and practices become more widespread available, and that people can access these interventions through a host of different options instead of having to come to our little small clinic. Lastly, this is just a little bit of a snapshot of the Victoria Safer Initiative's project timeline. So as you can see here, all the way back in June 2020, we started our service design and engagement with people who use drugs, completing the Victoria Safer Initiative Community Engagement Report and establishing the Safer Research Committee. And then we started up with clinical service delivery while we were completing more of that engagement and focus groups with people. Then we sought out additional funding extensions so that we can explore fentanyl-based options. And we introduced the Victoria Safer Initiative Clinic, which opened June 2nd of 2021. That's when the drafting and adaptation of Fentora, sufentanil, and fentanyl patch protocols began. And then we were able to start offering those programs within a month's time. And from that time, we've been taking feedback and the experiences of people who are accessing our program, and we continue to adapt and modify our protocols based off of the feedback. We have quarterly meetings with our prescribers where we tear apart the protocols and remake them. And oftentimes it's about changing dose ranges, about increasing accessibility, and about acknowledging some of the challenges and barriers that are fostered out of a medical model for prescribed safe supply. We're now working on things like knowledge translation and exchange, on building capacity with other services, and about exploring smokable options with the intention that we continue to see projects scale up, but we also integrate ourselves with evaluations both provincially and federally, so that there is the generation of that body of knowledge and evidence that we need so much. And that concludes today's presentation. But I will just add that our emails of both myself and our project director, Heather Hobbs, are on this slide. We are on Twitter, so feel free to follow us. And if you are looking for access to those prescribing protocols, they are available upon request. Thank you very much.
Thank you so much, Corey. It's quite impressive how much your team accomplished in brief couple of months. We'll welcome any questions people have. Feel free to add them in the chat here. All the medication options you shared, were they covered under the BC drug plan? Or did you guys have to do some advocacy or pilot?
We did have to do some advocacy. Not everything was available early on, not available through drug coverage. Our program actually covered the cost of the medications for participants as they got started, even if they experienced lack of drug coverage related to no MSP. We would pay for their medications out of our program cost and eat those costs while we figure out how to get them their ID and how to get them their drug coverage. We coordinated and collaborated with the provincial government to get these medications, the Fentora, the sufentanil, and the fentanyl patches, added to the drug formulary. It is through a complicated special authority process, and so we streamlined different templates so that we can make sure that the special authority process was consistent. We have benefited from actually some really positive responsiveness from the province in terms of trying to remove those drug coverage barriers. I know other provinces haven't had the same luck with their provincial government in terms of getting these interventions added to the formulary. And so I know that oftentimes if you're in a different province, you may be looking over and thinking, well, that's easy for you. But we don't have that here, and that's true. And we need more national advocacy and advocacy in all the provinces so that these medications can be covered, because these are options that should be available to everyone.
Yeah, quite impressive. And did you find, like, were there any tips or things that you felt was helpful in advocating or engaging with the government?
It was probably helpful to not have a conservative government in power. I would say I'm looking over at Ontario and looking over at Alberta, and I'm a nurse who worked in harm reduction in Alberta for quite a long time, and I know what my friends who work in harm reduction are dealing with over there, and it is not the same playing field that we are at here in BC. That's for sure. We have our own issues here, and things don't move as quickly as they should here. But truthfully, I wouldn't be able to tell you what to do, because there's amazing advocates in those provinces who are trying to push safe supply forward and are really running into a wall that's built on ideology and rhetoric. And so I think we all need to make sure that we're supporting each other. And I think sharing this evidence and participating in national evaluations and provincial evaluations is a small way to help open the door for other provinces that are experiencing these challenges, so that you can lean on the evidence moving forward.
Absolutely. Thanks again. It doesn't look like we have any questions. Thanks everyone for joining us today, and I hope everyone have a great Friday evening. Thanks again, Corey.
Thanks so much, everyone.